This is a Chronicle podcast, bringing you ideas in the service of medicine.
From the Chronicle podcast system, this is Vender on Psoriasis, with Dr. Ron Vender. Based on the popular Vender on Psoriasis column in the Chronicle of Skin and Allergy, Dr. Vender provides brief synopses of recent significant clinical developments in psoriasis research, and provides his observations and comments to accompany each report. In each episode, Dr. Vender will answer questions and offer his expert observations and anecdotes on treating this chronic disease. If you have a question for Dr. Vender, or want to be in touch at any time, just send an email to vender@chronicle.org. That's VENDER@chronicle.org. And, if you attach a voice clip, we might even use your question on an upcoming episode. Support for this podcast comes from Sun Pharma Canada. Sun Pharma is a world leader in specialty therapeutics, and is now positioned to be an even larger contributor to the Canadian dermatology landscape. Learn more at www.sunpharma.com. And now, here's Jeremy Visser.
Thanks, Leona. Welcome back. I'm Jeremy Visser of the Chronicle of Skin and Allergy. You're listening to the Vender on Psoriasis podcast with Dr. Ron Vender. In our 6th episode, Dr. Vender will be talking about biosimilars, biologics use, and the potential association of psoriasis with incident venous thromboembolism and peripheral vascular disease. Our first study looks at outcomes of a mandatory non-medical switch from adalimumab originator to adalimumab's biosimilars in psoriasis patients. Welcome back, Dr. Vender. What are your thoughts on this study?
Oh, thank you for having me back. This episode number 6 of the podcast. I have had several pharmaceutical reps and colleagues have told me that they enjoyed listening to the podcast, so it seems to be quite successful. So I want to thank the Chronicle, and I also want to thank Sun Pharma for sponsoring this, as well as Mitch and Alan from the Chronicle, of course. So biosimilars. Well, biosimilars are just that. They're biosimilar. They're exact. They're not generics. And so the study that looked at mandatory non-medical switch is essentially an economic type of study, a cost-saving study. That's why biosimilars were made. Biosimilars weren't made to offer new treatments for patients. They're made to offer affordable treatments for patients. Present time, there's no mandated switch, although this may change in the very near future, although the pandemic has caused this delay for some reason in terms of a mandated switch. And so what is meant by a non-medical switch? Is it meaning that it's not switched for medical reasons? In other words, it's not being switched because there's side effects to a particular component or a particular biologic, but just for cost savings. The biosimilar are just that, exactly the same, and are exact copies of the originator biologic. And in order for it to be approved as a biosimilar, they go through a rigorous process, although there are extrapolations that can occur from different disease entities. What I mean is that occasionally there may be a showing that there is biosimilarity in patients that have arthritis when changed over to a biosimilar with a switch, and this could be extrapolated to skin psoriasis, for example. Although there are many of the biosimilars that are released, and there are about 5 or 6 available now in Canada, that has shown that the efficacy and safety is the exact same to the originator, and the cost is substantially less. In other words, there does not seem to be any risk. In the past, there seemed to be a confusion whether there would be some drift in terms of immunogenicity or glycosylation. But we know that this drift occurs with originator molecules as well within acceptable levels. And so this does not seem to be a concern. There does not seem to be an increase in immunogenicity as well from the use of biosimilars. And some biosimilars, for example, adalimumab, less citrate or no citrate at all, which can be used as a buffer, which has been associated with some injection site reactions or some stinging. that does occur. And so there may be some benefits to using the biosimilars as well.
Our second study looks at risk of serious infection in patients with moderate to severe psoriasis associated with biologic use. What's your experience with this, Dr. Vender?
Well, thank you for the question. I know that everybody's practice is different. I have over 1,000 patients on biologics, and the risk of serious infection is extremely low. These biologic agents used for psoriasis are extremely focused and directed and targeted, and are very rarely associated with risk of severe infection. It depends on how severe infection is defined. Usually it means requiring hospitalization or discontinuation of a biologic, or requiring potentially intravenous treatment as well if it's bacterial. However, if looking at, for example, TNF inhibitors and tuberculosis, if this is considered a serious infection, which I would, the chance of reactivation of tuberculosis when properly screening patients and treating them appropriately is extremely low. The risk of sepsis is extremely low. The risk of, for example, serious infections such as with endocarditis is extremely low or not significant. And these risks of serious infection do not increase over time. So with longevity and patients staying on these molecules showed to be very safe, short and long term. And so my experience with a serious infection is minimal to none on these patients on biologic.
Our final study looks at a potential increased risk of incident venous thromboembolism and incident peripheral vascular disease in patients with psoriasis. What did you think of this study, Dr. Vender?
I'm interested in this study, and we know that psoriasis patients have numerous comorbidities such as inflammatory bowel disease, hypertension, diabetes, obesity, alcoholism, depression. And so this DVT or venous thromboembolism or peripheral vascular disease can be associated with other comorbidities as well that are known to be with psoriasis patients. The concern seems to be the potential future use of JAK inhibitors, and these have been known to be associated with higher risk of venous thromboembolism as well. The incident peripheral vascular disease is likely associated with the hypertension that occurs, the diabetes as well that are associated known with psoriasis. So yes, we can add these two to our list of comorbidities that the psoriasis patient has to worry about. Most recently, even renal disease was added. It just seems to be that the psoriasis patient cannot avoid any organ system with respect to comorbidities. And unfortunately, this study showed this increased risk of incident venous thromboembolism. And I know they calculated for confounding factors. However, in my psoriasis population, this occurs maybe in 0.1% of patients. So the risk is not zero, but it's there, but it's extremely low.
Now on to the listener questions. Our first question comes from Ottawa. How do you talk with your patients about changing treatment to biosimilars?
Well, thanks for the question, Jeremy, from our nation's capital. So I talk to my patients about changing a treatment to biosimilars very carefully, but I'm very comfortable about it as well. So at the present time, because at least where I practice, although this is not the same across Canada, there's no mandated switch. So the conversation occurs very infrequent. However, I did recently have a patient that was on adalimumab who has his own drug plan from his own company, costing him a lot because of this. And therefore, I offered him this biosimilar. And I approached it in a very simple fashion to say, there is a less expensive version of your adalimumab. It's still adalimumab. It's just adalimumab made by company X instead of adalimumab that has been made by your originator company. It's exactly the same. I tell them that it has been studied in, if not just in skin psoriasis, but also in other disease entities. They should not expect any different side effects or efficacy because it's exactly biosimilar. I explained to them that it's not a generic, which may have different components in it. They may find that the biosimilar has some benefits, such as reduced citrate or no citrate in the solution, which they may find it more comfortable, but they should not notice absolutely anything different between their originator and their biosimilar, except for a reduced price. They often are worried about whether they're going to have financial support for copay and so forth, but according to the biosimilar manufacturers, they're offering this to their patients so that they can enjoy a financially risk-free treatment of their psoriasis.
The next question comes from a listener in Alberta. What is some advice for talking with patients about the potential for side effects or treatment complications when discussing biologics?
Thank you for that question, Jeremy. So potential side effects and treatment complications when discussing biologics can be a very lengthy conversation. Sometimes we know that patients in an office, when you're talking to them, are listening with one ear and not listening with another. And therefore, having the patient think about a potential use or switch to another biologic is important. The pharmaceutical companies are very helpful with information, and the internet can be very helpful as well if going to the right website. I explained to them that all medications have risks, and I think that's just a common statement that physicians say to all patients anyway. Everything has potential side effects, although the risks for biologics are extremely low because of their targeted mechanism of action. But we know that different classes may have higher risks than others. So, for example, reactivation of TB, and I say to them, that's why we're checking for tuberculosis and so forth prior to this, especially with TNF inhibitors, the potential risk of candidiasis for the IL-17 class or exacerbation of inflammatory bowel disease. Screening the patients is very, very helpful for that. Headache and fatigue for the anti-IL-23 molecules are common as well. But I think that giving them the brochure provided by the pharma companies or the last pages of the product monograph that are made for patients will delineate all the potential side effects and making sure that they understand it and checking with these patients later.
Our last question comes from New Brunswick. Regarding the study we looked at, association between biologic use and risk of serious infection in patients with psoriasis, what are some tips on how physicians can interpret studies like this that are in clinical settings, but in real-world experience?
Well, thank you for the question from my home province of New Brunswick. Although I practice in Ontario, I was born in New Brunswick. And so this type of tip that I can suggest for doctors to interpret studies is to really look at your population to make sure that you're screening your population appropriately prior to starting a patient on biologics. If someone's had recurrent hospital infections prior to being on a biologic, it's sometimes unlikely that this recurrent cellulitis or these recurrent infections are not going to get worse by being on the biologic, but they still can continue. Now, occasionally, as the skin improves on the biologic, and if the serious infection came from a skin source or a skin start, then we'll see that reduced. I think that we have to look at our own patient populations and looking at the number of patients that you have on biologics. If you're comfortable with a certain biologic, there's certainly no reason why you can't continue with it. I dabble in biologics. I use all the biologics, so I have experience with them all because of the type of practice that I have. I need experience to be able to switch between biologics in case of any adverse events or lack of efficacy. And so I think that one has to look at their own patient population and carefully choose the patients that you put on biologic if you indeed have a concern about this. Although it's not a major risk to have these type of serious infections, I think that in general, physicians can be quite comfortable to say that these risks are extremely low.
Thank you, Dr. Vender. Listeners, if you have comments or questions for Dr. Vender, send them over. Send an email to health@chronicle.org. Add a voice clip attachment to your questions, and you might appear in a future episode of this podcast. If you enjoyed this podcast, please share it with your friends. You can subscribe at Apple iTunes, Google Podcasts, Stitcher, or wherever you get your podcasts. This podcast is produced in cooperation with Sun Pharma Canada. I'm Jeremy Visser of Chronicle Companies. Your host has been Dr. Ron Vender, founder and director of Vender Innovations in Psoriasis, a center of excellence for psoriasis offering a comprehensive management solution for individuals with psoriasis. Thanks for listening.